And so what I'd like to do is maybe I'm Jean Wyman from the University of Minnesota School of Nursing. You met me at the last competition, but I wonder if we want to go around and have each of the judges introduce themselves. I'll have maybe the St. Louis U judges introduce themselves first, and then we'll end with the other two Minnesota judges.
Hi, congratulations on advancing to this level. My name is Marla Bergwager. I'm from St. Louis University School of Social Work.
I'm John Morley. I'm a professor of geriatrics at St. Louis University, and I spent my first 5 years or 4 years as an assistant professor at the University of Minnesota, and left because it's too damn cold in Minnesota.
Davita Stalling, St. Louis University School of Nursing.
And Joe?
I'm Joe Gogler, professor in the School of Public Health at the University of Minnesota.
Thanks.
Good evening and welcome. My name is Jim Pacala, and I'm the head of family medicine and community health at the University of Minnesota and a geriatrician.
Thank you all. And now I'm going to turn it over to Group Team 16 from the University of Minnesota. And who is going to start off? Okay, Kendra, that's what I thought, but I didn't want to say that for sure. So take it away. I think you're muted still.
All right. Well, hi, everyone. Nice to see everyone again. This is our presentation for the geriatric case competition, and we are Group 16 from the University of Minnesota, and we are all very excited to be here today. My name is Kendra, and I'm currently a second-year occupational therapy student.
And my name is Kelsey. I'm also a second-year occupational therapy student.
Hi, my name is Emily Fay, and I'm a registered nurse in the second year of my Doctor of Nursing Practice program with an adult gero clinical nurse specialist specialty.
My name is Catherine Tyre, and I'm a second-year SLP student.
For this presentation, we are first going to meet the patient, Michael Jones, and discuss an overview of his complex patient case. We are also going to meet the interprofessional team and address the roles that building trust and considering race and health disparities play as a part of the case. Next, we will review his problem list and the associated goals created by Michael and the interprofessional team. We will also discuss the specific interventions and care plan we developed with the associated outcomes and measures, and then end with a summary of the lessons we learned as an interprofessional team during this experience.
Our patient is Michael Jones. He's a 76-year-old Black man who lives with his wife, Mary, in a rural community. And Mary was recently diagnosed with Alzheimer's, and she also suffers from diabetes, hypertension, and chronic back pain. Michael is Mary's primary caregiver. He's also a retired high school teacher who taught in his community for over 30 years. Prior to Michael's diagnosis, he enjoyed socializing with friends over bowling, beer, and pizza. Michael and his wife have been married for 40 years, and they have 2 daughters, Tracy and Denise. Tracy is married with 2 children, and she works as a nurse in the COVID-19 unit. Tracy has expressed frustration with how Michael's initial COVID-19 care was handled and believes his stroke could have been prevented. In her experience working at the hospital, she has noticed that certain patients get selective treatment based on who they are and who their physician is. Denise is their younger daughter, and she relies on Michael and Mary for financial support so that she can take care of her child with complex medical needs. Michael and Mary worked hard throughout their careers so that they could support their children in any way they need. Tracy has taken time off work to care for her mother while Michael is in the hospital, but she has to return to work soon, and the family will need to figure out who can care for Mary while Michael is recovering. Michael's health complications have drastically changed how the family is able to function.
The overview of Michael's case: Michael was initially admitted to the hospital due to COVID-19 complications, and after further evaluation, it was discovered that Michael had a stroke. He was transferred to the ICU, and while his COVID-19 symptoms appeared to be improved, he was left with some major deficits such as right-sided paralysis, trouble walking, and difficulty speaking. Michael also began to show signs of depression. Currently, he is cooperative with treatment, but often expresses sadness about being separated from his wife due to COVID-19 restrictions. Michael's pain level is currently at a 6 out of 10, and he feels especially fatigued after physical therapy. He requires moderate to maximal assistance for some activities of daily living, including dressing and toileting, He has been diagnosed with Broca's aphasia and moderate dysphagia that makes communication, especially with his wife, difficult and causes frustration. The family was already under financial strain before Michael's hospital admittance and are even more worried about how their finances will be impacted now. Michael's priority is to recover quickly so he can get back to taking care of his wife and being with his family.
Michael's primary care team consists of Michael, his family, the nurses responsible for his daily care, along with certified nursing aides and a physician assistant or medical doctor, an occupational and physical therapist, a speech language pathologist, social worker, nutritionist, neurologist, pharmacist, respiratory therapist, and a psychologist. The overall roles and responsibilities of the interprofessional team include open communication, providing client-centered care, integrity, punctuality, and respect. At the center of the care team are Michael and his family. They are the ones ultimately deciding on what is best for Michael's rehabilitation. It is the responsibility of every medical professional involved in Michael's care to provide him and his family with information on possible treatment plans. Many of the clinicians involved in Michael's care will be working to address the same needs, so it is important that effective interdisciplinary communication is established. All treatment plans and medications must be implemented simultaneously without negative effect on Michael.
Before working towards goals and developing Michael's care plan, we would like to create a stable relationship with Michael and his family, build better rapport, and address racial and health disparities. One way the interprofessional team can build trust is by utilizing dialogue communication. This is very useful when disagreements arise between the care team and patient and family, as one did involving Michael's care and stroke outcome with the lack of use of the medication hydroxychloroquine. Dialogue requires thoughtful, exploratory exchanges with the goal of enhanced understanding through the shared appreciation of identities, backgrounds, values, and perspectives that each patient brings. This type of communication makes the relationship with the patient more collaborative, where the patient is seen as the expert in their own self and life. Other ways to build trust include consistent patient and family education using evidence-based practice. For example, on why the team did not use hydroxychloroquine as a treatment regimen for COVID-19. Two other ways are having confidence when delivering a medical opinion and spending more time with the patient and their families, whether that be in person or virtually, considering the current pandemic. Now, when addressing race and health disparities, we want to first point out health disparities for the Black community with COVID-19. Black people are being admitted to the hospital and dying of COVID-19 at a disproportionate rate. The CDC reported on the racial trends of COVID amongst 534 patients of people admitted for COVID, where 45% were white and 33.1% were Black. It's important to keep in mind here that Black citizens only comprise about 13% of our population. In Chicago, for example, Black people were 3 times more likely to get COVID and 6 times more likely to die from it. Other health disparities amongst the Black race are that 30-day readmission rates have been found to be higher in Black patients discharged to skilled nursing facilities compared to white patients of the same facility. This has been found to be lower in Medicare patients with proper care coordination, like a case manager, which is something we kept in mind for Michael's care plan. It was also found that Black people are less likely to have an advanced care directive. Neither Michael or Mary have an advanced care directive, which is why it is important for nursing or the case manager to educate both patient and family on the importance of this and aid in completing one if accepted by Michael and his wife. Lastly, Martino et al. 2016 describes the roles that racial and ethnic disparities play in Medicare patients' care coordination. It showed that Black beneficiaries reported more difficulty getting timely follow-up on test results, less help managing their care, and that their primary care provider had medical records and pertinent care information less often during visits compared to their white counterparts. A major recommendation to address these health disparities, as previously discussed, would be to include the use of a care coordinator or case manager to help manage Michael's care plan. This will help to bridge the gap in communication between the patient and interprofessional team.
So some of Michael's immediate needs include a support system, which consists of his family. Right now, that means using telecommunication to communicate with his wife and his daughters, and also ensuring Michael's wife is receiving care and support. Another immediate need is symptom management of Michael's several diagnoses. Emotional and mental health support, ADL assistance, and assistance with immediate expressive communication are also all of Michael's immediate needs. In the long term, Michael needs continued interprofessional collaboration to ensure safety and health outcomes, long-term rehab care, in-home or caregiver support for his wife, resources for affordable services in the rural community that they live in, financial support, nutritional support, permanent supplemental assistance for himself and his wife, a home assessment, and an IADL assistance.
Goals for Michael and the interprofessional team. After discussion with Michael and working to understand his wants and needs, we collaborated on personal goals for Michael for short term, which include establish effective communication so he's able to speak with his wife, daughters, and other family members. Long-term personal goals for Michael include find a permanent supplemental assistance for care of himself and his wife, continue to help with the caregiving needs of his wife, which is what he highly stated that he highly values, and adapt to a new medical and living situation, which may require home or environmental modifications since his life has been altered by the stroke. Some interprofessional short-term goals discussed amongst the team with the inclusion of Michael for short-term include discharge from the transitional care unit or inpatient rehab facility. But first, we would ensure that Michael tests negative for COVID-19 before transitioning him, even though his symptoms are improved. And then it's important to counsel Michael on a realistic discharge location, such as a TCU, transitional care unit, or IRF, inpatient rehab facility, while recovering from his prognosis. There are different requirements for these locations that would be taken into consideration. An IRF is to focus on the restoration of functional independence, and the client would be able to participate in at least 3 hours of therapy from at least 2 different disciplines, along with the daily visits from a psychiatrist for his mental health. A TCU is often less intensive therapy, and rehab services are on a more as-needed basis. So we decided Michael would benefit from an IRF at this time because of his current needs, yet determination to get better as soon as possible. Another short-term goal is to further assess Michael's skills to build a comprehensive treatment plan, which includes the use of an AAC device to participate in testing, a PAS score, administer IOPI assessments, as well as implement additional OT assessments. This could include eventual home environmental assessments. These will all incorporate Michael and the family's well-being. Some long-term goals for the interprofessional team are to establish a plan for long-term care with speech, OT, and PT services, promote independence and activities of daily living, and ultimately improve Michael's health and well-being and establish a long-term living situation plan. And this could include meeting with a nutritionist and learning more about diet impact on overall health, and being educated on the benefits of having home health care for his wife and himself. Social work will be acting as the case manager for Michael and to ensure that the overall team is functioning effectively. Michael's interprofessional team will collaborate on his care plan throughout his time in an inpatient rehab facility and home care. His team will make sure that Michael's mental health is at the forefront of care by sharing resources and education, as well as being culturally competent and considering racial disparities while delivering care. All professions will focus on being client-centered and providing interventions that work towards Michael's short and long-term goals. The interprofessional team will collaborate on Michael's goals by using effective documentation and communication.
A communication process will be developed and put into place to ensure timely and effective transfer of relevant information at all points of access. The IP team will communicate face-to-face when possible, but primarily within the EMR. All members of the team will share timely, up-to-date information within 24 hours of patient updates and encounter, and each week his team will hold a daily care conference or rounds on Michael while he is still in the ICU. Shared information will be comprehensive with all relevant information on Michael, including his medications, progress to date, planned appointments, and ongoing recovery needs and goals. Electronic medical records will be updated regularly and used as the primary form of communication. All updates should be accessible through EMR. Feedback will be requested and given regularly. The social worker, who is also acting as the case manager, will be the liaison between the medical team and Michael and his family. Weekly family care conferences between Michael, his family, and the IP team will be held over Zoom or FaceTime. The IP team will work together, keeping the same goals in mind to support Michael's short and long-term needs. Effective teamwork will improve patient safety and health outcomes. Together, the IP team can improve Michael's overall quality of life through client-centered care.
Now we are going to discuss how we address Michael's needs as an interprofessional team. First, the nursing, primary care, and advanced practice registered nurse staff are an integral role in managing Michael's medications and pain, whether giving medications, education, or adjusting the treatment plan. They are also important in his mental health support by being a patient advocate, doing daily mental status assessments, and utilizing therapeutic listening and communication. Lastly, nursing staff, including both the nurses and nursing assistants, are an important part of helping the patient with activities of daily living and encouraging independence with these.
The social worker will act as the case manager for Michael, communicating with all members of the care team. For Michael and his family, the social worker will play a key role in educating them on possible care paths and providing information about Medicare services to reduce the financial stress Michael and his family are under and improve Michael's quality of life. Tracy's frustrations with the hospital will also be addressed. The social worker will also assess Michael's emotional needs and provide counseling services to address his depression. Michael has expressed frustration with the lack of affordable care available to him and his wife in their rural community. The social worker can explain to Michael the in-home services that Medicare provides and which of those services he is eligible for. It is important to note that in Michael's case, his wife's health and well-being is also a factor in his rehabilitation plan. The social worker must address all aspects of his rehabilitation, including determining the best plan of care for Michael's wife, who was recently diagnosed with Alzheimer's.
Occupational therapy will address his ADL performance to help Michael restore independence in ADLs, including dressing, toileting, and clothing management. Later in his care, OT will evaluate IADL performance and home environment safety assessment to work towards his goal of reestablishing his role as the primary caregiver of his wife. OT will also work with Michael to educate him on fall prevention and balance, as well as medication management. Increased independence will increase Michael's overall quality of life. OT will also help to identify coping strategies and stress management techniques to help with Michael's depression.
Physical therapy will work with Michael to regain muscle strength and assist Michael with ambulation and improving his overall mobility and stability, as well as collaborate with OT on other adaptive equipment. Finding adequate adaptive equipment will be important for Michael's independence at this time. OT and PT will work together to find the least restrictive assistive device for Michael's mobility, such as the use of a Hemi walker for better stability in moderate to severe imbalance limitations. We will also plan to give Michael a discharge rehabilitation plan, which includes physical and occupational therapy with the possible use of telehealth, as well as educational handouts for patients who have experienced a stroke. There will also be collaboration with a speech-language pathologist to improve postural stability and find adaptive tools for immediate effective communication.
Speech therapist results of Michael's WAB bedside assessment are consistent with Broca's aphasia with moderate apraxia of speech. And the Mann assessment of swallowing ability has also determined that Michael has moderate dysphagia and poses a mild risk for aspiration. Other members of the care team have expressed difficulty in conducting further assessments due to Michael's impaired speech and language capabilities. In order for Michael to complete necessary assessments and reduce some frustration he is having communicating with family members, the SLP will provide Michael with an augmentative and alternative communication device. Immediate therapy will focus on instructing Michael on how to use the device. After Michael has been set up with an AAC device, therapy focus will shift to addressing his deficits due to Broca's aphasia.
When tracking treatment and monitoring outcomes, we are going to look at both patient and activity-focused measures. Some patient-focused measures include patient satisfaction questionnaires and patient interviews. These allow us to get detailed descriptions of patient progress and attitudes towards Michael's living situation and outcomes. They also help us to understand the patient satisfaction and trust with the care from the interprofessional team. It would also be important to re-administer the PHQ-9 questionnaire to track how Michael's depression is doing. Another patient-focused way to measure outcomes would be looking at client records, which could be used to gauge Michael's compliance with treatment and rehabilitation. A potential activity-focused measure would be utilizing organizational records and activity logs to also track the number of therapy sessions completed and monitor progress towards therapy and nursing goals over time.
Transition planning for discharge to the most appropriate location will begin as soon as possible following the initiation of care at each applicable stage and setting. Right now, Michael is still in the ICU and will likely be discharged to inpatient rehab first once he will no longer spread COVID-19. Discussions, decisions, and activities will be ongoing and reflect changing needs and evolving goals. A transition planning process will be established and well organized. Collaboration between health professionals, patients, family, and caregivers will be critical. A goal-oriented transition plan will be considered, assessment of caregiver capacity, as we know his wife is not capable, and the use of telehealth modalities where available. Caregiver skill training will be included, planned, and goal-oriented day, weekend, and/or overnight visits to the identified discharge location and written discharge instructions as a component of an individual care plan that addresses the following issues as appropriate: functional ability at the time of discharge, risks and safety considerations, action plans for recovery, medications at discharge and instructions for adjustment, follow-up care provider contact information, and information for one point of contact post-discharge. All communication should be available in aphasia-friendly formats as required and appropriate to the health literacy of people with stroke, their families, and caregivers. While Michael is still in the hospital, daily care will include nursing and nursing aides or assistants, family, which will be virtual, psychiatry, OT, PT, and speech, and of course, Michael. As Michael progresses and meets his goals, this might become more weekly rather than daily support. Weekly support will be provided by the case manager or social worker. Bi-monthly meetings will be held between primary members of his care team. Pharmacy, nutrition, and neurology will be included in Michael's plan as needed. With this care plan, we hope to see Michael discharged safely and continue to meet goals based on the plan we have implemented. We also hope to see Michael's quality of life improve with continued care and therapy.
Working together on this case study truly taught us so many valuable lessons about the importance of interprofessional care. Our team met several times over Zoom and collaborated well for each section. Members completed tasks as they were expected before each meeting. Overall, the process felt smooth and we had great teamwork and open communication. We learned that it was important to take a collaborative approach and widen the scope of viewing the case to more than just looking at our specific profession's goals, but rather looking at Michael's case as a whole. We also learned that multiple members of the care team can approach the same aspect of care for a client, making interprofessional team communication and collaboration critical. When reflecting, we realized the importance of taking responsibility for your own actions and understanding the role and scope of practice for each IPT member and how each can make unique contributions. Each interdisciplinary team member recognizes health disparities, acknowledges cultural differences, and are advocates for racial equality when providing care. Thank you for listening to our presentation tonight.